Hello and good day, everyone. My name is Nur Adlina binti Zainal Abidin, and I am from the Master in Molecular Medicine ODL program from International Medical University. Today, I am going to present my research proposal titled An Investigation of KRAS Subtype Mutations Found in Lung Cancer Patients Within the Malaysian Population. Before that, I would like to introduce the contents that will be elaborated in this presentation, which will consist of the above. Firstly, we will introduce some background study and literature reviews regarding the topic. Next, we will have the research questions, research objective, and hypothesis, as well as the significance of study for this investigation. Later on, we will have the research methodology overview on the breakdown of it for this investigation. And lastly, we will have the project milestones and references presented in this presentation. So, what is lung cancer? Lung cancer is when there is a presence of abnormal cells that are cancerous growing primarily in your lungs. It is a common cancer known worldwide in the second highest mortality rate according to Globacon 2020 report on cancer. In Malaysia, however, it is the third highest mortality rate for cancer, just behind colon and breast, as reported by the Malaysia National Cancer Institute Registry report. Lung cancer is described to be more common in the male gender in comparison to female. This deduction was made based on most of the people who tend to have lung cancer are also tobacco smokers. Overall, the report statistics experts have made a deduction that the death rates caused by lung cancer will have an increase by at least 47% by the year 2024. Some background info on lung cancer. It can be categorized into two types, which is SCLC and NSCLC. SCLC is known as small cell lung cancer and NSCLC is known as non-small cell lung cancer. And as you can see, the rate of people diagnosed with NSCLC is higher by 85% in comparison to SCLC. NSCLC can also be further broken down into three types, which are adenocarcinoma, squamous, and large cell carcinoma. Adenocarcinoma is by far the most common type of NSCLC diagnosed in lung cancer patients and has a high rate of 60% within the population. These are the common oncogene drivers found inside lung cancer. There is EGFR, ALK, ROS1, KRAS, BRAF, ERBB2, MET, NTRK, and PDL1. According to the National Cancer Comprehensive Network (NCCN) clinical guidelines, clinicians are highly recommended to do molecular testing for these biomarkers if the patient has confirmed to have lung cancer diagnosis for the histopathology report on their biopsies. Today, however, we will focus more on the KRAS oncogene driver for lung cancer, which makes up of 20 to 25% of the cases. KRAS is known as the Kersten rat sarcoma viral oncogene and is one of the three members of the RAS family, which makes up of KRAS, NRAS, HRAS. The RAS oncogene family encodes small membrane-bound enzymes, namely called GTPase or guanosine triphosphatase. They function as molecular switches between an active GTP and an inactive GDP in the cellular signaling pathway. This cycle of turning on and off like a light switch is prompted when an external stimuli like growth receptors are high in concentration in the cells, promoting guanine nucleotide exchange factor in the KRAS gene, inducing activation of GDP to GTP. Hence, activation of GTP will lead to some downstream effector signaling such as MAPK, PI3K, and RAL pathways. These pathways are involved in cellular signaling for cell proliferation and survival. Hence, KRAS plays a substantial role in cellular signaling for the cell survival. For decades, the KRAS gene has been targeted by researchers alike either directly or indirectly for the development of treatments such as farnesyltransferase inhibitors and impairment of KRAS downstream signaling. However, after many unsuccessful attempts, it has been deemed to be undruggable. But then, in 2021, the Food and Drug Administration FDA approved of a drug, AMG 510, now known as sotorasib, to be used for treatment of patients with NSCLC KRAS G12C mutations. In the literature review section, According to REC-M team and Adio A and their team, in 2021, they both described the challenges in targeting KRAS for treatment development and how even with the emergence of sotorasib as a drug, there is also some resistance found within 50% of the patients that have taken the drug. They described the resistance mechanism due to this patient signaling pathway not being solely RAS dependent. This is because in most of the patients, they develop a resistance by developing additional mutations like ERBB2 and MET amplification that could bypass the RAS protein in activating cellular pathway like cellular proliferation. In 2020, Rupert A. and team carried out a prevalence study within the French community regarding the clinical outcomes associated with different KRAS subtype mutations, and they conclude that there are some discrepancy between these two variables, and later on was agreed by URAS and Jude J. and their team in their reviewed papers as well. The research question that will be looked into for this investigation is, what is the distribution of specific KRAS subtype mutations in patients diagnosed with NSCLC within the Malaysian population? Does the patient's demographic have any effect on the emergence of different KRAS subtype mutations and their severity? Do different KRAS subtype mutations have significant variation on the patient's clinical outcome? The research objective for the investigation that will be carried out are to determine the prevalence and distribution of KRAS subtypes in a group of NSCLC patients within the Malaysian population, to investigate the association between specific KRAS subtype mutations and the patient's demographic, as well as to discover the clinical outcomes of patients with specific KRAS subtype mutations. The significance of this investigation being carried out is as presented: to have a better understanding of the KRAS subtype mutation groups in the Malaysian population among patients diagnosed with NSCLC and to identify its prevalence in the population. It is also to find the association between the patient's demographic and the KRAS mutation subtypes involved for improvement in diagnosis and advanced testing. It is to discover the overall clinical outcome that arise from specific subtypes of KRAS mutations for the development of treatments in the future. The null hypothesis for the investigation will be that the prevalence and distribution of KRAS subtype mutations found in NSCLC patients vary significantly within the Malaysian population, and these specific subtype variations are associated with distinct clinical characteristics, thus affecting clinical outcomes, whereas the alternative hypothesis will be the opposite of what is presented here. Here we have the overview of the research methodology that will be carried out for the investigation. We will start with sample collection, which will be based off a few criteria for selection and in the form of extracted DNA. Then we will quantify and dilute the DNA accordingly for nucleic acid amplification. In this step, we will use commercial PCR primers from the QIAGEN KRAS Screen KRAS Pyro Kit. Once PCR is done, the product will then undergo preparation for annealing to sequencing primers before being loaded into the sequencer for pyro sequencing. And lastly, the data will then be analyzed accordingly using softwares like ANOVA and PyroMark Q24 software. We will start with sample collection, where the samples will consist of extracted DNA from patients with KRAS mutant lung cancer that has been extracted from cell blocks or formalin fixed embedded paraffin blocks, FFPE. Preferably, the blocks that are extracted are within the 5-year timeline period, due to any biopsies that are older than that will have an effect on the pyro sequencing results quality due to the animation. These biopsies have also been diagnosed with lung cancer by the histopathology lab with recorded results. After we have our samples, we will have to quantify the extracted DNA using the nanospectrophotometer, and ideally we should have a ratio of within 1.8 to 2.2 for the A260/280 ratio. This is to indicate good quality DNA has been obtained. The DNA will then be diluted to 2 nanogram per microliter of concentration as recommended by the handbook TerraScreen KRAS Pyro Kit for nucleic acid amplification with the responding primers. As you can see here in figure 3 is a summary of mutations being covered in the TerraScreen KRAS Pyro Kit, and in figure 4 is the protocol that will be used for nucleic acid amplification. Both of this information can be obtained from the TerraScreen handbook. After PCR is done, the PCR product will be immobilized by using Cephirus beads in order to help with the denaturing process to become single-stranded strands, using the PyroMark Q24 vacuum probe as seen in figure 5. After the product has become single-stranded, it will then be annealed to the sequencing primers at a heat shock of 80 degrees Celsius before being cooled down for loading into the sequencer Pyromark Q24. Pyrosequencing is used because it is both a qualitative and quantitative method, where it uses a sequencing by synthesis method. The data will be represented in a histogram and peaks will be visualized to see specifically which regions the changes have occurred. Controls are also present in the run to make sure that the runs are all of good quality. This method is also high in sensitivity with a limit detection of as low as 1.0. The sequencing data obtained from the Pyromark Q24 sequencer will then be analyzed into the Pyromark Q24 software, where examples of the analysis being done can be seen in Figure 7 and 8. Each peak in Figure 8 represents the nucleotide found in that specific region and the changes that have occurred. Besides the sequencing data, collection of data from the patient's demographic and clinical outcomes will also be recorded to obtain the prevalence and association between the KRAS subtype mutation variables and the patient clinical characteristic variables. All of this data will then be plugged into software like ANOVA for further analysis and presentation. As you can see, it is presented here, the estimation period of investigation that will be carried out summarized into a Gantt chart within the 10-month time frame. You can see here sample selection and collection will take around 3 months, while molecular profiling for pyrosequencing will take around 2 months. Data collection will take around 5 months, and data analysis will take around 3 months in concordance with scientific writing and presentation. These are all the references that are used for the presentation. Thank you all for your kind attention and have a good day.